Hello and welcome back. We're now going to talk about the operational side of what it takes to implement digital pathology in practice. Now, I'm sat here very fortunately with Josefin Persson, who's the laboratory manager here at Region Skåne. First, Josefin, thank you for joining us.
Thank you.
I'd like to look at the operational impact of digital pathology, across this healthcare site. Where has the change been most tangible in day-to-day practice?
I think the most tangible is the patient safety.
Okay.
And it's due to the quality from the laboratory. And then we have the connection between our systems for the patient. Because before you have the slides, then you put it in the microscopy and then you watch it. But there was no connection between the slide and the list system.
Yes.
And nowadays you have the connection between the list system and the viewer.
Yeah.
So it's always the same patient you're looking at.
So there's very, very little danger, or perhaps no danger.
No danger today.
No danger of accidentally switching
Exactly.
slides. Patient for patient.
Yeah, so I think that's the most important thing. And then it's the quality. And I think also the awareness is the people who works in the lab, how the result is in the end, because before you didn't know if it was good or a bad section, for example.
Yes, okay.
So
it's kind of a better relationship between histotechnicians and everyone else.
Much better, yeah.
Yeah, okay, interesting. To move the conversation on then, how has digital pathology affected turnaround times, or we usually call that TAT really, don't we?
Yeah.
Across the service, and where in the workflow has that improvement been most visible?
I think it's saved a lot of time in many ways. Most in the before the technicians heading out the slides to every pathologist. Nowadays they don't do that work anymore.
Yeah.
And the scanning part is not doing by the technicians, or it's doing by other stuff. So I think we save a lot of time in the laboratory, which thing makes a better place. And for the pathologists, it's much, much better because they don't have to search for the slides all the time.
Yeah. And then, to put a number on that in terms of turnaround time, what did turnaround time look like before you began digital pathology to the end now?
We did some statistics for part of a few years ago, and I think we changed it from 22 days now, and we're in 12 days.
Okay.
Yes, I think 10 days saving.
Okay, amazing. Yeah. And this, your workflow, having spoken to you beforehand, it sounds like it's constantly evolving. So with that in mind, do you think turnaround time will continue to decrease?
In some part, but in some parts we are having extra information. There is AI that are upcoming, and I think it would be turning down the TAT in future, but it takes a long time to implement.
Yes.
So I think the standardization and that kind of thing we're doing now is around 10 to 12 days is a good goal.
Yeah.
And I think it's hard to push that down because we do extensive analysis today compared for 10 years ago.
Yeah.
You didn't do the molecular at all. And now we have to wait for the molecular answer to get the whole report to the patient. So I think 10 to 12 days is a good goal.
Certainly, yeah. I'm aware that you kind of have a connected healthcare centre here. How has digital pathology allowed you to exchange cases and distribute them between multiple sites, and what's the significance of that?
It's back to the slides for our 4 cities or 4 sites in Skåne and are connecting to each other. So that was our biggest problem. We're sending slides to each other every day to consulting.
Yep.
And nowadays we're not sending any slides to each other for histology. And it saves a lot of time because even if Malmö and Lund is close by, like 2 miles, it takes like 3 hours to send a slide from the one to the other. And then this should be registered and taken care of with our secretaries. But that doesn't happen anymore.
Yeah.
So you just call your colleague in another city and tell them, can you go into this case and look and help me out?
Yes,
and then you can help each other out in the same time.
Yeah. And your pathologists, do they work mostly from home?
No.
No.
Most of them work in place. And it's most because of you have to have this connection between each other, and then you have the grossing part.
Yeah.
And then we have the fresh tissue to take care of in Lund, for example. So some of them working on the distance.
Yes.
Yeah.
But most of them work on site.
Yes.
Yeah. Okay. And actually, having done a lot of remote working in my time, I think that human contingent and being with a group of people who are all working to the same cause is incredibly important.
Yeah.
Yeah.
So I think more of them can work in distance, but we have to have some experts in place as well.
Yeah.
Yeah.
Yeah. Okay. Thank you. And to talk about quality then, whole slide image quality, how have you seen that improved with bringing on this digital workflow?
From the beginning, before we started up the project for digital pathology in 2018, we set up a project that optimized lab flow. And we do the standardization from the grossing. The size of the tissue shouldn't be bigger than like 2 centimeters. And then we have this placing in the blocks, so you can do the cutting later on very smoothly. And then we realized that many of our process put in a lot of tissue in their blocks, and when you should put the tissue in the slide, everything couldn't be scanned because the scanner has this marking on the slide, so you couldn't scan the whole area on the slide.
Okay.
And that was kind of new for many. So you have to change a lot of protocol before. I think that's the most important thing to do before you even start to scan. Is to optimize your grossing part. So smaller piece and smaller amount of tissue in each block.
Yes.
Yeah, that's very important.
Perhaps to go a little bit off our question rail here and look at your initial approach, what would you have done differently now, knowing what you know? You mentioned there that, changing your grossing process is incredibly important when considering how you scan slides. Is there anything else, specifically, I guess, with the scanning side of things, that you would change looking back?
Not really. I think the journey we went to was good, but I don't think we could change a lot of things. We have changed things after we started as well. Very close to the start, we changed the thickness of the sections. Before we all do the slicing or cutting in 4 microns. And after a short while, we changed it to 3. That was a big step for us. Because it's much harder for the technicians to do the 3 microns sectioning compared to 4. So it was a hard work for the technicians, but the result on the slides was amazing. So,
talk us through that quickly. How did you have to adapt your, I guess, grossing stage in order to do that?
Before this biggest problem is that we were 4 sites. So every site has to do done exactly the same. And I can tell you, no one did the same from the beginning. So you have to convince every technicians and the pathologists to do this. That was a huge work.
In terms of, you said it was much more difficult for a histotechnician to cut at 3 micrometers rather than a larger size. What's the reason for that, and how did you adapt to it?
The reason was when you do the scanning, if you do a thicker section,
Yes.
it's harder to see all the cells in the wavelengths and down to the deep.
Yeah.
And then the result was a lot of cells were on focus.
Yeah.
And then we have to do the rescan.
Yeah.
And we don't want to do the rescan, so we have to change something. And then we thought the thinner section is the better way to go.
Yes.
But we just told the technicians to no, it's free.
Yeah.
Now you have to do the 3 microns.
Yeah.
And all our immunolaboratories always do the sectioning in 3 microns.
Yeah.
So it was not all technicians that didn't like it, but most of them.
Okay.
Yeah.
So you said it was more difficult to cut at 3 microns rather than a larger size. So can you talk us through that?
Yeah, it's difficult if you don't, if you ever don't have to do with a microtom. If you take a thicker section, it's easy to catch.
Yeah. Okay.
Yeah. So when the catch moment is hard to get when it's thinner, and then you should take it even in a water bath or placing it right to the slides. It's easier if it's more thick.
Okay.
And if it's a hard tissue to cut, it's also easier to do more thick.
So obviously with pathology going digital, and we kind of leaned on this earlier, but we've now got the option of remote reporting. You know, was that a real benefit for your staff here to have the option of reporting remotely as pathologists?
I guess so.
Yeah.
Everything that's easier and don't take time, unnecessary time, is better for everyone, I think.
Yes. Yeah. I suppose a happier livelihood for some people who want to work from home. Yeah, they can have that option.
Yeah, I think so. Sometimes it's better to have people on distance because they're doing more right work in distance. They're not disturbed by a colleague open the doors or the telephone rings all the time, and I think it's great. But I can say that the production of the slide is the most crucial thing in the laboratory.
Yeah.
Yeah. So we have to train the technicians as well in many ways, because before, when you took a slide, you do this finger marking on the slide.
Yes.
Not by any reason, but when you should scan this slide, slide will have to be clean.
Yes.
So you can't take a thumb on the slide because the scanner will detect the prints.
Okay,
so we have a lot of dust and that kind of stuff as well. So that was one good thing to notice also.
Okay.
Clean slides before the scan.
Okay.
Yeah.
Thank you. I think that's a really key point, and I'm glad we can share that with any labs that are looking to take this step.
Because it's hard. It's hard to scan slides in a proper way.
If you compare the services that you offer in pathology now from when before you were digital to where you are now, having a digitized workflow, are there any obvious operational frictions that have disappeared with that?
I think the flow between lab and diagnostics is much smoother, more seamless.
Yes.
And even if you compare to other support, it's easier as well, because we're seeing same things when we talk to our operators.
Yep.
And I think it's easier to work with the clinicians as well, because they can check in our different system what we're talking about. So when they have our MDKs, when you're sitting with radiology at the same time, it's very much easier today than before, because before they come with all the slides in a huge racks, and then they should show it in a microscope and no one understood anything.
Yeah.
So now it's much better.
Okay.
But I think Kevin can talk about more about that.